Welcome to our continuing 2018 educational webinar series. I'm Catherine Short, Partnership Marketing Specialist for First Healthcare Compliance. At First Healthcare Compliance, we help you with a comprehensive compliance management solution tailored to your business, a hospital, hospital network, healthcare practice of any size, billing company, or skilled nursing facility. As part of our complimentary educational webinar series, we bring you experts from around the country to discuss relevant topics in the healthcare industry. We are so pleased to have Pam Joslin of Innovative Healthcare Consulting with us today. Pam has more than 20 years of medical practice management, billing and coding reimbursement, auditing and compliance experience. She is an engaging presenter via webinar, classroom, and conference on various topics that may impact each step in the life of the revenue cycle of every practice. She has managed in medical practices ranging from single to multi-specialty groups, including ASC, and is an advocate of process improvement and maximizing and empowering employees to bring about the best practice results for your organization. She has received her master's in management from the University of Phoenix. Pam maintains memberships in professional organizations to support her continuing cycle of learning in the ever-changing healthcare industry. A copy of the slide deck is available for download on the control panel. Feel free to submit questions in the question box of your control panel during the presentation. We will address questions at the conclusion of the presentation. Your Paycom CEU certificate will be emailed to you from Paycom following the broadcast. There is no need to request it. Additional CEU opportunities will be available to BC Advantage members following the live broadcast. See their website for details. A download of the handout should be available for members, available with a button at the bottom right-hand side of your screen. Pam, welcome.
Thank you very much, Catherine, and welcome everybody, as we're going to be talking about understanding the CERT findings. And the CERT stands for the Comprehensive Error Rate Testing. That's part of a CMS program. And some of the results and the information that we have is going to help you look at what your organization should be monitoring. And taking a look at the CERT findings is a great opportunity for any organization. It doesn't matter what size you are, because it helps you identify the potential errors and look at them the same way that auditors are going to do. So there's millions of physicians, across the United States. And when you're setting up your auditing organizations and you're looking at, what parameters should we be auditing, taking a look at what is being measured by the CERT is a great opportunity to help you know what is being targeted or what is high-risk information that CMS is looking at. So I want to welcome you. I realize that discussing CERT findings is not something that you may talk about over coffee or tea, in a regular management meeting, but I hope that by the end of the presentation and sharing this information that you do make it a practice to go in on an annual basis, look at the information in the CERT findings, and do make it a regular part of the conversations that you have on your compliance and your management team. We're going to talk a brief history, the objectives of CERT, the CERT process, and then the last thing we're going to do is look at the Health and Human Services Agency financial report. I just have some excerpts from that. I have the link. It's 70-some pages of great information. So I have the link there for you at the back on the resources page, and you can go in and just pull the information that's relative to your organization. So we're looking at this CERT. It was released in January of this year. The reporting year for it is 2017, and the claims that were submitted came from July the 1st, 2015 to June the 30th of 2016. So let's just take a little brief history if you're not familiar with the comprehensive error rate testing. And if you are, this would be a nice review for you. So back in 1996, the Medicare fee-for-service improper payment rate was beginning to be measured. The Department of Health and Human Services and the Office of the Inspector General were responsible for estimating this national Medicare fee-for-service improper payment rate from 1996 through 2002. So when we talk about improper payments, we understand as healthcare entities that it's just not good enough to think that just because something got paid, that it should have been paid. There needs to be some type of auditing pre-payment wise, because if you do everything, it's valuable to do post-payment, of course. But if you don't do any pre-payment, then all the errors have already been sent out of your system to CMS. So auditing prepayment before you send it out your system and external payment, there's a delicate mix there as well. So originally, the Office of the Inspector General designed its sampling to estimate a national Medicare fee-for-service paid claims improper payment rate. But they only had a small sampling back then. They were only sampling around 6,000 claims. So with all the millions of providers and the claims that goes into Medicare, I think you would agree that just the small sampling of 6,000 really didn't give them a good sampling of what was going on there. So the OIG was unable to do an accurate report for the improper payment rates by contractor, contractor type, service type, and provider type. So the sampling size was increased when CMS began producing the Medicare fee-for-service improper payment model back in 2003. And the goals, the objectives of the CERT program is to calculate the Medicare fee-for-service program improper payment rate. They select a stratified random sample of about 50,000 claims now, going from 6,000 to 50,000 claims that's being submitted to Part A and to Part B through your MACs, or your Medicare Administrative Contractors, and also your durable medical equipment, or your MACs for your DMAC during this reporting period. So the CERT program looks at payments that should have not been made or that was paid at an incorrect amount, and this includes overpayments and underpayments. So when you're looking at setting up an auditing monitoring process in your organization, you want to be looking at overpayments and underpayments as well. And it's also important to note that the improper payment rate does not measure fraud. It just estimates the payments that did not meet the Medicare coverage, coding, and billing guidelines. So already off the start, just understanding there's some criteria that we have that is measured in the CERT program that you can certainly mirror in your organization. And doing what this program does, it refers back to the Medicare coverage, coding, and billing rules or guidelines. So first step in your organization, that would be part of your structure, whether you're actively engaged. Sometimes we kind of get busy and we deviate from what we were doing. But if you're looking at setting up a proper program that mirrors CERT, those would be a couple first steps. So because we're looking at the fiscal year, that was the reporting year for this report. And the Medicare fee-for-service program improper payment rate is 9.51%. But that's less than 10%. And you think, whoop, whoop, that's really good for all the Medicare claims that is billed out. But in essence, we have to look at the monetary loss for that as well. And it represents $36.21 billion in improper payments. But compared to the fiscal year 2016, the improper payment rate was 11%, and give or take a few, $41.08 billion in improper payments. So we are doing a little bit better than last year. So the table on the next slide is going to look at the improper payment rate and the projected improper payment rate for the fiscal year 2017. And once again, just a reminder of how the cycle works. The reporting period for 2017 goes back from July the 1st, 2015 to June the 30th, 2016. So we look at the service types on the left-hand side here. And this is what you're going to see consistently through the presentation. We have Part A. These are the providers that are excluded in the hospital inpatient prospective payment system. We have Part B providers, and we have our durable medical equipment, prosthetics, orthotics, and supplies. And then we also have hospitals that include the inpatient prospective payment system. So I didn't do the expanse of information. I did not do all of the slides for all of these service types. I do have some that's in comparison, like this one, but I did randomly, pulled some of the service types so you could just get a sense of how you need to choose your service type, your entity, go into this document and pull all the relative information that will help you be successful. So in the improper payment rate, overall was 9.51. You had the Part A without the IPPS was 11.31%, which is $18.24 billion. Moving down to Part B, theirs was $9.85 billion for a 10.16% improper payment rate. The durable medical equipment, prosthetics, orthotics, and supplies was a 44.60% with $3.65 billion. Looking at the hospital IPPS, 3.91 for a $4.46 billion. All combining into 36.21 billion in proper payments for this reporting year. So let's look at the steps. So when they calculate the Medicare fee-for-service improper payment rate, the first step is this random sampling, the one that went from 6,000 to around 50,000 Medicare claims that they pull. So looking at a portion of the claims in this report, you'll see that it was sampled for the 2017 report year. It was unviewable because the claim adjudication process was incomplete. And that means that the MAC or the Medicare administrative contractor had returned the claim to the provider or the supplier. So they pulled the 50,000 claims, and then there's a portion of them that were unviewable. So then the second step is a medical record request. If your organization, your provider has been lucky and they're one of the 50,000 that has been pulled in this stratified random sampling, then they identify that claim as part of the sample. And then they will request the documentation. They're going to send you a letter, ask for the associated medical records for that sampling and any other pertinent documentation from the provider or the supplier who submitted the claim. And what you need to understand about this as well, if you are a DME POS provider and clinical diagnostic or lab services, in addition to the request sent to the billing provider and supplier, the referring physician, if you are a referring physician and that is part of the way you do business with your patients, you can expect to also receive a request for documentation. And they do this because sometimes a referring provider maintains the documentation to support the medical necessity of the services that have been billed. And should the CERT program receive no documentation within the 75 days of its initial request, it just scores the claim as an improper payment, and it's filed under the no documentation criteria. And we'll look at that in just a minute. And the CERT program also will make phone calls to validate the provider's or the supplier's contact information, and also address any questions that you may have about the request that you have received. And they send at least 3 subsequent letters, and when the provider or supplier fails to respond within the initial request, here's where you have the 75 days to the initial request, and then it's going to pop over in the no documentation era category. Review of the claims and the assignment of the error categories. So once again, this is very important information as you're structuring your auditing program and what you should be looking at, just reviewing the basic error categories that they look at. So the medical review professionals, they look at the claim, submit documentation, make a determination of whether the claim was paid or denied appropriately. These reviewers generally include nurses or physicians, unless this task has been delegated to some other licensed healthcare professional. So they review the documentation, the CERT programming examines the CMS claim system. They're looking for Medicare Benny eligibility, duplicate claims, Medicare as the primary insurer. So when looking at the claims review, the CERT program checks for compliance with the Medicare statutes and regulations, which tie to the information in the National Coverage Determinations, NCDs, and the LCDs. And after they're looking at this information, they've made the determination, then the reason for the improper payment comes over to the error category for the claim. Here are the different error categories that each of these claims is going to be placed in. Either there's no documentation, insufficient documentation, incorrect coding, lack of medical necessity, or some other problem. So the no documentation claims get placed into this category when the provider or the supplier fails to respond to the repeated request for the medical records, or when the provider or supplier responds that they don't have the requested documentation. This is definitely something that you would want to have part of your auditing. And if you do this before you send out the claims, then you will be aware that there's no documentation for the claim that is queued up for you to send out from your system. Looking at insufficient documentation. This means that the claims are placed into this category when the medical documentation that's been submitted is inadequate to support the payment for the services that are billed. So in other words, your CERT contractor reviewers could not come to a conclusion that the billed services were actually provided at the service they were billed and if they were medically necessary. So if your claim is placed into this category, where there's a specific documentation element that is required for payment, this means that that particular element is missing. This can be a physician's signature on an order or even a form that's required to be completed as part of the claims cycle. So looking at incorrect coding, claims are placed into this category when the provider or the supplier submits medical documentation that supports a different code that is billed, that the service was performed by someone other than the billing provider or the supplier, that the billed service was unbundled, or that the beneficiary was discharged to a site other than the one that is coded on the claim. And then we have medical necessity. If your claim is placed into this category, when the CERT contractor does the reviewing, looking at the adequate documentation from the medical records that has been submitted, they're going to make an informed decision that the service billed was not medically necessary based upon the payment policies and the Medicare coverage guidelines. And then other. Of course, we have to have another category and everything. So if your claims make it to this category and there was an improper payment and it does not fit into any other categories, maybe it's a duplicate payment error or a non-covered or unallowable service, or maybe this was an ineligible Medicare Benny that they discovered during the sampling. So the CERT program will notify your local MAC of the improper payments that have been identified through the CERT process. Then it's your local MAC that's going to repay the underpayment and recoup the overpayment from your entity. And tracking appeals, providers, suppliers, beneficiaries have the right to appeal any of the improper payment determination that's made by the CERT program, provided that they meet the filing requirements. And it should be noted that there is a minimum amount in controversy for each of these levels that must be met before you can dispute the claims. So I gave you just, this is from, you have the links over here on the right side. You have the time frames, the level of appeal, the summary of the review process, who performs the review, when must you request an appeal, when should you get a decision, and the links to each of these forms. And I also have the link to this table back on my resources page. So when they're looking at determining the improper payment amount, each of the max contribution to this overall improper payment rate is proportionate to the share of the total Medicare payments. So the CERT program projects the sampling to be the claims of what they call their universe statistically. And these calculations meet a national precision of 2.5% points. 90% confidence is required by the Improper Payments Elimination and Recovery Act of 2012. So they have their own statistical information that's behind the results that you're going to see in the report. And when they report the results, this claims universe, or the sampling, includes all the claims that have undergone final adjudication by the MACs, regardless of their final decision, whether they decided to pay or reduce or deny the claim. And the improper payment rate includes both overpayments and underpayments. So the reconciliation of the improper payments, then the CERT program is going to notify your local MAC of the improper payments identified through the CERT process. The MACs then are going to repay the underpayments and recoup the overpayments. And MACs can recover the overpayments that have identified in the sampling, but they can't recoup the projections that's made to the claims universe. So the overpayments on the claim sampling of the report we're getting ready to look at during this time period was $36 billion. All right, let's look at the Department of Health and Human Services Agency Financial Report, better known as the HHS-AFR. So we've talked about the history, we've talked about the process, and like I said, I've just extracted some important tables. I touch on all the service areas, the two under Part A, Part B, and the DME POS. And the recommendation, this report is like 70-some pages long, but as an entity, it will be easy for you just to scan through and see which ones really apply to you. So this is a document, a supplement for the improper payment information. This is an annual report. This one here, like I said, was shared around the first of the year, 2018. So just knowing the time frame when the claims are generated, when the reporting period is, and when the report is available would be something that you would want to monitor in your organization. And you see that this used to be the IPIA for the Improper Payments Information Act back in 2002. 2010, it became Improper Payments Elimination and Recovery Act, or IPERA. And then 2012, they changed it to the Recovery Improvement Act, IPERIA. So this organization has undergone several transitions. And what this does, it requires the improper payments reporting in this HHS annual financial report. So the Centers for Medicare and Medicaid, or CMS, they measure the Medicare fee-for-service improper payment rate through this comprehensive error rate testing. So let's look here. This is the payment accuracy, the 90.5% accuracy rate, and the 9.5% improper payment rate. So look at the 90.5%, and you'll, like we talked before, oh, less than 10. Well, that's pretty good. But look at the money. You also have to look not only at the percentage, they also look at the monetary loss with a 9.5%. So the 90.55% is $344.6 billion. But then in the little gold piece of the pie, you see the 9.5%, and it's $36.2 billion of improper payments. So here on the right-hand side of the circle, you see the categories that we talked about and how they measure them. And this is important because when you're looking at your auditing system or you're getting ready to set up auditing process or you want to make improvements, these are the 5 criteria that when you send your claims to Medicare that they're being measured by. So I think that it would just make sense to use part of the same measurements that your entity that's may audit you is going to be using. So looking at the dark blue at the top, that's the other, the 3.6%, and we looked at what other meant. The no documentation is right after that with a 1.7, and then we have the incorrect coding, which is 13.1, and then the medically necessary is a 17.5%. That's the goldish piece of the pie, and insufficient documentation, 64.1%. So these are the findings based on the improper payment error rate category. So here we're going to look at it by service type. We have the DME, POS, they're first in our graph, and then we have the Part A, and this excludes the hospital IPPS. And then right beside that, we have the Part A, hospital IPPS, and then Part B. So in comparisons for our different service types, you can see that Part A, and these are all, of course, grouped into the other slides that we've been seeing. So we saw the total amount, and it was starting to break it down. The report starts to break it down as far as individual responsibility for the different service types. So you see the DME, POS, they and Part A and Part B struggle with the most of their improper payment rate, insufficient documentation. So if you're in those organizations, that would be part of what you would want to be monitoring and giving feedback to your providers. And then the Part A hospital, the IPPA, they have a little different struggle than the other service types. They have a struggle with proving medical necessity with their documentation. Okay, here's the same criteria, only we're comparing home health, the skilled nursing facilities, inpatient rehab facilities. And here again, the home health, the skilled nursing facilities struggle with insufficient documentation, and for the inpatient rehab facilities, their largest portion of the improper payments are through not meeting medical necessity. So they don't just measure the percentages, they tie the money to that, which makes it more real to all of us. So looking at the no documentation piece of that, and the monetary amount was $613.24. The incorrect coding was 3686.87. Medical necessity is the 6334.76. Of course, we have then we have underpayments because this looks at overpayments and underpayments. And then we had insufficient documentation. And see that's tied through all the previous slides that we saw, where insufficient documentation in most of the entities was the problem for the improper payments. And this is in millions of dollars. So we look at insufficient documentation errors. There's a report inside of this report. So as you're structuring what you're going to be looking for in your entity, this on the left-hand side here, this graph, missing inadequate orders, and that means that there's a valid provider's order or intent to order for certain services for the service supply that has not been submitted. Missing an adequate plan of care. a valid provider's plan of care for the service has not been submitted. Missing inadequate records, a required record has not been submitted or has not been fully completed. Inconsistent records. The records submitted have inconsistent information in that. Maybe it's the date, provider, service, BINI information, etc. Or there's an incorrect date of service that just doesn't match up with the claim that was sent out. And then the last universe, error name and definition, is certification and recertification. And that's where the certification, recertification requirements are not met. So within each of these error categories, you also have the opportunity to break that down because these are considered root causes of the insufficient documentation error. So when you're communicating with your providers, the more detailed information and the root causes that you can give them, the better success you'll have in improving as you move forward with your program. All right, here is what it looks like. The universe errors at a percentage of the improper payments due to the insufficient documentation. Here's the breakdown that we just talked about on the other slide. Certification, recertification, that was a 29.8%. Inconsistent records, 6.1 is the missing inadequate orders. Then we have the missing inadequate plan of care, which is only the 1.5%. 26.3% of this insufficient documentation was missing or inadequate records. And then we have the multiple universe errors. We have, of course, like they're other. All right, here's the claim type categories by percentage of insufficient documentation, improper payments by universe errors. So we have your Part A, including and excluding the hospital IPPS. You have your Part B and your DME POS. So let's take a look at that. Part A, what they struggled with in the insufficient documentation realm is their certification and their recertification. Looking at Part B, they had some problems with the missing inadequate records. Also looking at inconsistent records, that was a problem for Part B. The missing inadequate orders, once again, the Part A that excluded the hospital IPPS, that was an issue with them. And the missing inadequate plan of care as well for Part A. And looking at the multiple universe errors, once again, Part A, that was part of their challenges as well. All right, looking at the percentages of insufficient documentation payments by the multiple universe errors, once again, the 4 different entities. Looking at Part A, the certification, recertification of the missing inadequate records. And also struggled with the certification, recertification, inadequate plan of care, missing inadequate records, certification, recertification, missing inadequate orders, and inadequate plan of care. And they were also lumped into the other combination of the universe errors. Part B is the winner there with the inconsistent records and the missing of inadequate records. So that would be a gold mine of information for you in your practices if you're in Part B and knowing how to monitor that. Okay, these are the states. And like I said, not all the slides that I put all the presentations because it would just go on forever. So I just chose some that I thought was key to understanding more about the CERT process. So look at the top 3 states, Texas, California, and Florida. For as long as I've been looking at the CERT report, they have been the top winners for years. They do have a lot of population. They have a lot of Medicare population. So here we look at the claims that was reviewed, the projected improper payments, the improper payment rate, the 95% confidence interval, and the percent of overall improper payments. So Texas, their projected improper payments was the millions, 3,805,400. and that's a 14.8% rate. And the overall percentage of improper payments for Texas billing to the Medicare fee-for-service was 10.4%, followed by California, 9.8%, Florida, 6.9%, and it starts to drop off after that. Here's the second page of that. I did include that, and looking down at Vermont, North Dakota, Arkansas, Rhode Island, gets into the 0.1%. So you see the variance back here with Texas having 10.4 and the lowest being 0.1%. This is by service type for each of the claims. Once again, this is great information for you as well. The winner here is having the most improper payments are your lab tests, other than the non-Medicare fee schedule. Established office visits. Look at that one. Established office visits is number 2 with a 5.5% improper payment rate. And here we have the topics. I like this because this would help you if you're looking at your office visits or any of the services. I didn't include all of this slide. So this table D1, I kept that on the PowerPoint for you as well, because it would help you. If you see a report that you want to get more information, then going to the table will be more time efficient for you. So let's just say we're looking at established office visits, and you have insufficient documentation for the established as part of the sampling is 29.8%. Here, the medical necessity was 0, incorrect coding was 67.6%, and then none in others. So their overall improper payment rate was 2.3. 2.3 also for the hospital visit subsequent. You have office visits that are new. You have insufficient documentation. With that is 15.8%. So you understand why there's all of this, all these efforts in healthcare to streamline E&M and also do more and more coding audits with your evaluation and management, because the insufficient documentation is very well represented on this CERT report. Okay, here's something else that is good for you to look at, is you can pull this report from the initial report that talks about your individual specialties. So here we have internal medicine, and we're looking at the improper payments by provider, by claims type as well. So your internal medicine, they reviewed 1,841 claims from the sampling was pulled. The improper payment rate for them was 13.3%. Clinical lab, that showed up in the last slide as well, ambulance services is high with a 1.9% of overall improper payments. Then we get into family practice and cardiology, physical therapists in the private practice, hematology, oncology, emergency medicine, psychiatry, rheumatology, physical medicine, rehab, diagnostic, radiology. So you see with internal medicine, 3.6, and then it starts to drop off into the 0 point percentages. So quite a contrast there for the first couple, the clinical lab and the internal medicine. So what you should be doing is looking at this report, and it goes on for pages. This is just the beginning of it. Looking at your specialty and looking at what the improper payments criteria and what the errors are within this individual reporting, because that's a great opportunity for you to mirror what CMS and what's going to be reflected in the CERT program moving forward. So here's the second page of that, where we have radiation oncology. And looking at the percentages, and you say, oh, 0.3%, that's pretty good. But look at the payments, not only looking at the percentages, but looking at within their random sampling, how much that 0.3% for radiation oncology is going to be. physician's assistant, interventional pain management, general surgery, moving on down. Yes, dermatology is very low with the 0.2%, but looking at the improper payment rate, 2.4, and what that equates out to in millions of dollars. Okay, E&M. I couldn't leave our webinar today unless we talk about E&M. This is a great report as well. It's on table K4. So subsequent hospital care, the 99233 code, the projected improper payments, the percentage there, the 95% confidence interval is 11.8 to 14.8, but the improper payment rate for subsequent hospital care billing codes is 13.3%. Emergency department visit, and then we get into the 99214 and look at the projected improper payments for that. So here's just the first page of the final E&M codes, the projected improper payments. So once again, once you pull your service type, then you get your specialist, digging into the E&Ms and doing some pre and post payment auditing if you are not actively involved in that. But definitely try to get in a routine. I think you'll be surprised as to what you find, and you could use this as a definite guide to your auditing process. You have your 9921413 that are up there, and your initial hospital care, and then it drops down into the 99204, 215. Very, very common codes here in all of our practices. Because if you see the improper payment rate with this 50,000 random sampling that they pulled, and you do your own sampling within your organization, what is that going to look like in your own individual population? That's the way that you want to think about approaching using the information here in the CERT program to add value to your organization. Here's the provider type and each claim. This is the one I was talking about that I think is really gold. It's table J1. You have your chiropractic. What do they struggle with? 89.9% is insufficient documentation. The clinical labs is insufficient documentation, 97.3% as well. Pain management, insufficient documentation. So you see how the beginning of the slides and the area categories, and these are just looking at each of those categories at a much deeper level. So you can actually pull these reports and compare how your own service type universe would compare to the CERT findings. Once again, with optometry, this is the second page of that. Podiatry having 80.0% insufficient documentation. Medical necessity is 5.4% for podiatry. Okay, this is the part A, excluding the hospital IPPS, inpatient rehab hospitals. Their type of error, 99.5% on medical necessity. Looking at the inpatient rehab unit, insufficient documentation of theirs is 15.7, and the medical necessity is 84.3%. Looking at their improper payment rate is 34.8 for the inpatient rehab unit. So once again, it doesn't matter what entity you're working in, there's valuable information for you to go and do a prospective drill down. So I added this last slide here for you to look at the overpayments and the underpayment rates, because this is another thing you want to be monitoring, auditing and monitoring in your organization. So this is on table L5. It's overpayment rate on all claims type. It's a 9.3%. We saw what that looked like on the our circle graph in the beginning of the presentation, but looking at the dollar amount. And that's the way you need to look when you do your monitoring within your organization, is calculate a rate, because you want to be tracking this information. And you may say, oh, well, we just, have a 7 or 8% overpayment rate. But if you calculate the dollars amount that is tied to that overpayment rate, it'll make it more real for your organization. And then you'll be able to track and trend that and see how you do on a regular basis. And underpayments, those need to be tracked and trended in your organization as well. There was an underpayment rate amount of 0.3. But look at the total sample of the dollars that was paid, sample dollars underpaid, and projected dollars that were underpaid. All of that is still significant. So you want to make sure that when you're doing your auditing and your monitoring, that you are also looking at the underpayment rates. I wanted to include, this is a CERT contractor information for you. You will get, a letter from them. That's part of their process. You get multiple letters, but be mindful of the time frame, because you don't want your information to go into the no documentation category just because you lost track of it within your organization. You actually want it to be credited and looked at so that you're not part of the error category. Maybe what you're sending in will validate. You need the documentation with the information they have. So you definitely do not want to miss this process. So there's all the information for you. Here's some resources that we talked about. You can look at the CMS program. There's some information on compliance, the statistical information about CERT, if you want to do more training in your organization, and then the report that I shared with you, all 70-some pages of it is there for you as well. So I just want to hand this back over to Catherine to see if she has any questions for the Q&A before I do my closing comments.
Okay, great. Thank you, Pam. We do have a few questions. The first question was, I work in a small practice. What do you recommend on how to start with monitoring CERT findings in my practice?
Oh, Catherine, that is a great question, and we get that all the time. Small to medium-sized practices actually still struggle with maintaining their compliance program. But when you look at the risk of not doing the monitoring, you can see the figures here, and this is from 50,000, in the sampling, but each of the entities, you're going to have your own error rates and your own underpayments or overpayments that's unique to you. And what I recommend, this is just my opinion, and I've seen this a lot, is that you may have to hire someone to come in and set this structure up for you, because generally practice management in a small practice wears a lot of hats. And it's just not feasible for that person to be able to initiate and monitor this process. So having someone come in from the outside, set up the process, do the compliance training, set it up, and then if there is someone in the organization that can be trained and there is time to do that, you can transition some pieces of that to them on an ongoing basis, and then just have that consultant eventually just maybe become an independent entity to help with the external processes. So there's different ways to do that. The goal is to at least have something in place that's a working document and that you're actually doing. If you don't have an auditing process in place, what's worse than that is having a bunch of policies and procedures in place that your organization's not following.
True. Okay, so I had a second question here now. So how can I get my providers engaged in caring about CERT findings?
Oh, that's a great question too. And what we have found is that we kind of call it the written word. Us consultants that deal with providers and large organizations. And when a document like the CERT that comes out on an annual basis, this is great information that you can share with them to engage them, because this is everybody. This is everybody. All the specialties, all the service types can be part of the 50,000 that they choose randomly on an annual basis. So being proactive, you have all the information within the CERT report. Doesn't matter what provider, what entity you work for, there's some valuable information there. So share it to them. They can generally acclimate to, they're very good at acclimating to their own specialties. They like to follow that report that has the specialties and the type of error categories. I think that would be a great place for you to start.
Perfect. Thank you. We have another question here now. Are there outside resources available to help get this going in my practice?
Yes, I have links for you as to why you need to get going. There's compliance, there's auditing organizations that you can find through specialty organizations with all over the United States in your area. Maybe connect if your doctor is a part of an organization. Try within that organization to reach out to see if they have someone that could help you with setting up your auditing program.
Okay, great. And it looks like we have another question here. Who would be responsible for this process in a medical practice?
Generally, it falls under the compliance officer, but like one of the other questions that we had, the small to medium-sized practices struggle with the proper structure. Generally, this is compliant. The compliance person that's doing the auditing needs to report to the CEO and bypass the other structure, just for lack of conflict of interest and all of that. So it would generally fall under the compliance officer within that particular structure. If you don't have a compliance officer, I've shared information, get in contact with an organization that maybe you or your provider is part of, and kind of start with them to see how they recommend. If you get someone that's used to your specialty, then that will be a lot easier for everybody to get up and running with us.
Great. Well, thank you so much, Pam. I know that our attendees can contact you with your contact information there. Did you have any other final thoughts for our attendees? Any other tips or advice that maybe you thought of?
Well, thanks, Catherine. Just in closing, I hope that you agree with me. The CERT study is a gold mine of information, and it helps every service type be able to identify the potential errors and look at them the same way that auditors are going to do if they're pulled for sampling. And for a long time, if you're in healthcare, living in a what if I get audited world is kind of the culture that we have to have because it's just where we have grown to be in healthcare. So hopefully just one of the biggest takeaways that you have is that the CERT findings allow you the opportunity, no matter your service type, no matter what your specialty is, to identify your potential errors the same way that anybody is going to come in and audit for you. And I think that that's just very good information. It's a great place for you to start. And even if you're actively engaged in auditing, maybe there's with some additional information to where you could expand your own random sampling that you do within your entity. These are, these are the core basics that's measured by CMS, and generally, of course, you're going to have other factors as well. But having these core findings and the CERT document is a great way to start because you can develop your own random sampling. You need to have your error rate that you can track. So hopefully you found a lot of value in, even though it wasn't something that you talk about on a regular basis with your team. that once you get more acquainted with this, you set up your program, that it becomes something that you do talk about on a regular basis with your providers and your staff.
Okay, great. Thank you. Thank you. Well, I wanted to thank you again for that. And so if we could use the contact information on the screen, and also if you could please use, if you have any other questions, and if you think of them later, you can forward them on to us, and we'll send them to Pam. Please remember your Paycom CEU certificate will be emailed to you directly from Paycom within 2 days following the broadcast. There's no need to request it. You can also register for future webinars or request a demo of our compliance solution on our website, which is firsthcc.com, or call us at 888-543-4778. And thank you for joining us.